Welcome, everyone. My name is Bridget Zapita, and I am the Clinical Relations Manager for Heidelberg Engineering. I would like to welcome you to our webinar tonight, Beyond Imaging, Elevate Your Anterior Segment Workflow, presented by Dr. Carolina Rocha. Dr. Rocha is a professor of ophthalmology, the Arturo and Holly Melosi Endowed Chair and Fellowship Director of Cornea and Refractive Surgery at the Medical University of South Carolina's Storm Eye Institute. A diplomat of the American Board of Ophthalmology, she specializes in cataract, cornea, and refractive surgery, and currently serves as Director of Cornea and Refractive Services. Dr. Rocha has earned her medical degree in Brazil and completed ophthalmology training, a PhD focused on optical aberrations in pseudophakia and cataract, and advanced fellowships in cornea and refractive surgery at the Cleveland Clinic and Emory University. Her research centers on IOLs, optical aberrations, ectasia, and presbyopia. An internationally recognized educator and researcher, Dr. Rocha has authored more than 300 scientific publications and is an associate editor of the Journal of Refractive Surgery. She has received numerous honors, including the ISRS Case Beer Award and the AAO Senior Achievement Award. We will take questions from the audience during the presentation, so please submit questions into the questions pane throughout the program. Please welcome Dr. Rocha.
Thank you so much. Thank you for joining us today. I'm happy to be here to share, our experience with this SwepSource OCT device. We've been using this technology for over a year here at the Medical University of South Carolina. I'm really excited to be here. This has been really changing our practice, our anterior segment practice. So our goals today is we're just going to talk about the anterior and the technology and how we can really use this technology for refractive surgery, ectasia progression, cornea cases, cataract evaluation. And this is really amazing how we can combine those high resolution imaging with artificial intelligence for phakic IOLs. So just let's talk a little bit about the technology, for the ones that are not familiar with the anterior device. Right, but the imaging is just unbelievable. This is a SwepSource OCT with 1,310 nanometers, the wavelength, and that gives us this really wide visualization of the anterior segment, is 16.5 millimeters. And as we can see here, I think for the first time we have this imaging in clinic. It's really deep. It's 14 millimeters deep that we can see epithelium, stroma, endothelium, the anterior chamber, and all the details of the lens. And the axial resolution is actually less than 10 microns. It's really fascinating. So what do we measure with this technology? So we talked about the cornea, right? It's about 8 millimeters here. And the corneal thickness, your true ACD, right? Endothelium to anterior lens is our aqueous depth, white-to-white measurements. And then all the Purkinjes of the eye by ray tracing. So anterior cornea, anterior lens, posterior lens, and as you can see here, a very precise measurement of the axial length. And what has been very successful in our practice, this is a real-time measurement, and it's so fast. As you can see here, this is your corneal imaging, and you can change to your cataract measurements and metrics, and then the imaging device. But as you can see here, again, this is really real time. It's so fast, and it's really easy to teach the technicians how to use this technology. We work with a lot of residents and fellows, and it's been very successful. So let's start showing here the cornea, right? So the corneal data, as you can see here, again, the anterior takes 65 radio OCT scans with over 16,000 data points, over 8 millimeters. And the sync case, your corneal power is calculated from all the scans, right? So for when you're doing your cataract measurements, we're looking at all this data within the central 3 millimeters that is centered on the corneal vertex. And the anterior gives us this total corneal power that is, again, so important in cataract surgery, in refractive surgery, right? And this is all based on the SEPSWARS OCT. And this is what we call really the true corneal power, because it's not based on the whole eye data. Some devices, like wavefront devices, you're basically measuring the entire eye and then subtracting the power, the whole eye wavefront minus the cornea. But with this technology, again, is really true measurements of the anterior and posterior cornea within this central 3 millimeters ring. Well, this is a little brief overview of this technology, and we'll be here, of course, for questions at the end. But I just want to really show, in our practice here, why we're using this technology, and a lot of case examples. So in refractive surgery, in ectasia progression, patients with keratoconus, before we needed to go back, in the machine and look at different maps, and then export the maps, and you can actually customize your screen. And here is showing again 2 measurements, 2 data points with changes in the sync over time. But of course, we want to look at your difference map at the same time. So this has been really very helpful. You walk in the room and then you have your customized map. Here again, you see different time points, and we have our anterior Kmax, our posterior corneal Kmax, your elevation points, and also changes in pachymetry over time. So very helpful for ectasia progression, and also to assess treatment outcomes, right? INTEX, CARES, CTEC, and corneal cross-linking. So very helpful, easy, right? So all the information that you need it's there for you. So we're going to start with some corneal cases. I'm also a cornea specialist, and we really use this technology all the time. I'm just finishing clinic, and several patients here that we did the measurements, because again, it's really so fast and so easy to capture those high resolution imagings. So since this is a patient that had a history of a DSEC and had a rejection of the cornea, as you can see here, patient has bullous keratopathy and corneal edema, and we treated with steroids, subtenon's steroid injections, and she comes back. Vision is much better, and we can see the improvement. And this is also helpful even to show the patients, right? They understand how they are improving, how the treatment is working for them. It's again very easy to show the patients. We also use this technology for corneal scars. This is a patient, a 48-year-old male, that had a Pseudomonas infection, a Pseudomonas ulcer, and now he has a paracentral stroma scar. And we started losartan treatment for him. His visual acuity is improving, and it's really nice to be able to follow, the density of the scar with the SEPSWARS OCT. And also, when you're planing, for example, a PTK, right, really to measure the depth of the stroma scar, it's very helpful when you're planning treatment. This is another severe case here. This lady had a corneal transplant for a stage 3 neurotrophic keratitis. She perforated, and again, this is after a corneal transplant, and she comes in with this almost decimetocele here, and the anterior very helpful, showing severe thinning, and we glue this patient. We did a torsorrhaphy. We didn't want to do another graft with, again, very, very high risk of perforation, but it's so easy then to follow and see that, you know, that exact point she was getting better. And we still, you know, we didn't need to redo a transplant to do a corneal patch graft. And every time she comes in, we recheck and see how she's doing. A lot of different cases we see, but this is a patient with corneal dystrophy, lattice, very severe, and he had a transplant in the fellow eye. This is his better seeing eye. As we can see here, very regular, poor vision in both eyes. He had a transplant in the left eye, and he was seeing well for the first 4 weeks. He comes back 5 weeks after surgery, and corneal edema, diffuse edema post-transplant, and that's what we see. So very hazy view, but basically he had a Decimus detachment from the corneal graft, from the PKP that was done just a few weeks earlier. But it's, again, we were not understanding why he was, you know, doing well, diffuse corneal edema, and just by taking a picture, we can see that he had, again, that Decimus detachments with anterior synechia, very severe. So the plan here, we needed to repeat the graft. We could not save this cornea, but it's one case that it really helped us to not wait to see and try to treat this patient. Steroids, clearly here we can see that with this detachment and the anterior synechia, this patient needed a graft. So again, a lot of applications for corneal imaging, really easy, and we definitely use every day, you know, to plan treatments, corneal scars, corneal ulcers, thinning, DMAC, DSAC, CARES, CTAC cases. And we're going to move a little bit to talk about cataract evaluation. With the beauty with this technology, it really reduces the need for all the different devices that we have in our clinics. For example, if you have your optical biometer, then your corneal topography, tomography, and then a corneal OCT, you know, we have all that in one device. So the Cataract app will give you the SYNCASE, right? We talked about the 65 radio cuts, you know, with 16,000 data points of the cornea, but it will give you your SYNCASE for the central 3 millimeters, K1, K2, your true ACD, lens thickness, and your axial length from ray tracing. And you can visualize, you know, patients even with really dense, mature cataracts, as we can see here. You know, this patient number 2 here, very dense lens, shallow AC, narrow angles, but we are you can still get really good readings in those cases. And then you can really customize all the formulas, right? So your lenses, your preference, it's very similar, I would say, you know, with any of the optical, new generation optical biometry devices here. You can just customize, add your formulas, your toric lenses, and you have all your IOL calculations. Again, here, you know, if you're setting for first minus, or near plano, right? Your toric calculator showing you, the final axis for the lenses. Well, I think even when we started with this technology, we're so familiar with the Iomaster 700. We know it's very precise, and that was the first question. Are the measurements similar? It will give us the same level of precision and prediction error that we have with the Iomaster 700. And there are a lot of publications comparing the Antirion with the Iomaster 700. This one was published at the American Journal of Ophthalmology. The data, the sample size was, 116,000 measurements with surgeons across Europe and the United States and Asia. And the results were impressive, with definitely high level of agreement between Ks and TKs, values with 93.98% of eyes with absolute difference of 0.25 diopters or less. So again, very similar. And we looked at some other studies, right? We published at the journal Cataract and Refractive Surgery in 2021 from different authors, Abhijit Roy and Oliver Fondo here, Peter Hoffman. So a lot of different publications showing agreement with the Iomaster 700. So this is great. So we're not starting from scratch. There's a lot of published data there showing the precision for the cataract app. So the Matrix app, it's basically the one that gives you that entire photo of the anterior segment. So it's when you're looking at the anterior chamber volume, lens thickness, phakic lenses, the vault, you can look at the vault, and you can look at the angle metrics, and again, anything that you want to study. So we have some really good cases here that I want to share today. So for glaucoma specialists, this is also very helpful, right? So if you're doing a study, if you really need to have precise information about the angle or the sclerospur, the angle opening distance, the trabecular iris spur angle. So I think for glaucoma specialists, this is also very, very helpful. So now that what's really powerful, combining high resolution imaging and artificial intelligence. So there's we call Safe Vault. Safe Vault is a new software that basically what we do, we export the horizontal matrix imaging. And this is based on AI, right? And that will give you a prediction of ICL vault for the EVO ICL lenses. Again, this has been validated and published at JCRS with over 800 eyes. And this is with Damian Gatnell and Alan Sayad. And they basically use this AI method, right, to look at the prediction error. And it was really great. So it was within 250 microns in 81.7% of cases, and within plus and minus 300 microns in 90.7% of cases. So again, it's really easy. We're not using immersion or UBM. Touching the eye is a really very quick measurements. I actually had a few patients in clinic today that we used the new ICL sizing algorithm. So I just want to share here one of our cases. So this is a patient with history of keratoconus and had a Ferrari ring actually in Brazil, and now he is in the United States. And his refraction was -12 with +6. diopters of astigmatism. He corrected to 20/30 in the right eye, and -9 with 3 diopters, correcting to 20/20 in the left eye. And for ICL sizing, we measure, the white with different devices. We have our digital calipers, our Iowa Master 700, our Panticam, the Anterion, and this is our anterior ACD measurements. So just based on all the measurements, when we look at the DFU, right? So the DFU for this very complex case, it was telling us, no matter what we're looking at the numbers here, the range was a 13.2 or 13.7. And we took the photo metrics with the anterior and we used the AI software. But then here, I'll show you another photo here with the safe vault. Basically, the recommendation was at 12.6. Right, so it's telling me, about between 400 and 500 microns vault. So one size, right? If I was using the DFU, I would definitely get a really high vault in this case. So, and that was so precise, even in this complex eye. So we end up using a 12.6, and this is the post-op results. So really great tool for surgeons using, phakic IOL, ICL cases, right? And to monitor these patients over time, if you have a high vault or low vault, if these patients are developing cataract, it's really a technology that we're using on a daily basis. And then finally, the imaging app. So the imaging app, it's similar to Metrics, but you can customize. Basically, you can customize the length of your scans, radial cuts. Again, as you can see here, right? You have all that grid, and if you want to just the radial cuts. And this is very helpful for, corneal ulcers, corneal scars. You can really just study a very specific area on the cornea, lens, or your angle. So this is the imaging app. So again, for the ones that are learning, you have your cornea. If you want all the topography and tomography maps, cataract, your for optical biometry, ray tracing, you're measuring the axial length, plus, your corneal measurements, and then metrics and imaging. Metrics we use for the ICL sizing, and imaging if you really want a very specific area to study, with this high resolution device. Again, it's really, really fast to take all those pictures, and you don't need to move the patients around. So I think for the workflow in clinic is really helpful. All right, more cases. So this was another interesting case. So this patient is a 63-year-old female that came in with a little bit of corneal edema for the first time, and I think the doctor that saw this patient initially missed that this patient had really anterior cells in the anterior chamber. So the doctor ordered a just the anterior, just to look at the scar and the corneal edema, and then patient was back in the room, and the doctor was looking, was like, wow, we can really see AC cells with this technology. It's incredible. So then it really helped to make the diagnosis was a herpetic endothelitis, right? So this patient needed PO. We started on Valtrex same day, and steroids, and then her vision is now basically back to normal. Here's the same patient, right, showing some very specific areas and changes in the endothelium, just to have an idea of the resolution that you can see AC cells. For scleral lens fitting, it's really great, or very helpful for optometrists that use this this technology. Amazing resolution here. And for LASIK in general, just to look at your flap architecture, with femto, and if any issues, for example, interface fluid syndrome, you can see those areas of pockets, epithelial ingrowth, great resolution. And post-op, if you're looking at lens tilt or decentration, you can see all the details here of the IOLs. Another thing that I want to mention, we had a case, maybe when I come back next time, I can present. There was a patient that developed a cataract after intravitreal injections. And we had a question if that patient had a compromised posterior capsula. And actually with this technology, we were able to see. So we're prepared for surgery, right? With the intravitreal injections, probably touch the back of the lens, and that patient had a compromised posterior capsula. So that was another great case. Yes, thank you so much for joining us today. Just want to really share, how we're using this technology in our practices, again, for cornea cases, refractive planning, keratoconus progression, outcomes of refractive surgery and corneal treatments, and cataract and IOL calculations. So thank you very much. We'll be here to answer questions.
Yes. Okay. Thank you, Dr. Rocha. So again, I'd just like to take the chance to remind the audience that if you have not asked a question already, feel free to use the questions pane on the navigator, and we will go ahead and take those questions live with Dr. Rocha now. If for some reason we cannot answer the question live during our program, we can answer that in a follow-up email after the session. I do have some questions that I will get to right off the bat. The first question is, in the mapping program, when you're looking at corneal maps, are you able to compare any map in a follow-up progression pattern?
Yes, you can, right? And it was I had some cases here of keratoconus and after cross-linking or intracorneal ring segments, you can really customize your maps, and it's been so easy. You can just export if you have any a system, and for us Epic and Foreign, you can just export that map. And it's so easy because, we have all the maps, all the follow-ups. You don't need to go back and open every single one. You can see, for example, changes in Syncase, changes in Kmax, changes in pachymetry over time, and elevation maps.
Good. Okay. And are you incorporating post-op imaging into your standard of care now that you have the Antirion device?
Yes, especially for cornea and refractive, we don't measure every single pseudophakic patient that is doing well, but for cornea and refractive, yes.
Okay. And how do your patients feel about looking at the images? Are you sharing the images with your patients so you can show them where things have changed?
Yes, and the patients, they really appreciate, sometimes, especially with corneal ulcers or scars, sometimes the vision is still the same, but it's so reassuring when we show the imaging and say, you're getting better, the scar is getting better. Or cataracts, that huge cataract, shallow chamber, narrow angles, they really understand, how they can benefit from, for example, cataract surgery and some other treatments. And it's helpful, for example, explaining why the patient may not be a good candidate for LASIK, but it's a good candidate for ICLs, it's really showing the anatomy. I tell the patients, another patient one day, oh, this is like an MRI of my eye. I was like, yes. High resolution PET scan.
Good. Okay. And a question for you as well. When you were evaluating this technology, what was it that convinced you that it was comparable to your other biometer or your Pentacam?
Yeah, I think again, we're so used to the, for example, Iowa Master 700 is very popular. There's some other great biometers available, right? I think at the beginning you may take photos, to compare, but we don't need to start from scratch. There's a lot of published data there already. So that's, that you can trust, right? Not only one publication, but several publications.
Good.
AJO, JCRS, right, showing that the measurements were not different.
Good. Any advice on imaging bleb morphology on the Anterion? Blebs. So
Um,
I might be able to answer this a little bit. I think that the best way to image a bleb on that Anterion is really to build one of those custom scan patterns in the imaging app. And you can build as many lines as you'd like in a volume scan. You can do a radial cut scan, and you can even crank up the resolution depending on what you're really looking for. If you really want to see filtration through the bleb, you can when you build that the scan pattern appropriately.
That's a really great point, because with the imaging app, you can really customize. That is really amazing, and you can save your settings, right? So again, if you're a glaucoma specialist or cornea specialist, what are you looking for?
Does the Anterion come with all of the typical options in your biometer, IOL calculators and ICL sizing?
Well, for the IOL calculations, you can enter the formulas in your IOLs. The ICL sizing, it's a special app we call the Safe Vault. You still need, hopefully in the future, right? That's what we want. We're asking you guys to do
Yes.
that. But now we really need to export that metric photo and use this as special software, the
Yes,
Safe Vault.
Yeah, it's a special software third-party application at this point. Looking to have a partnership with that group in the future, directly integrated into the device. But yeah,
that will be incredible to have that there.
All right, and then can you please expand on how often you're using the ICL sizer with your patients?
Yeah, so for every single case. I mean, I had 3 cases today. We do a lot of studies here at MUSC at the university, and we still measure, we use our calipers, our Pentacam, Iowa Master. We know that the Iowa Master white to white basically always, Iowa Master always overestimate the measurements, right? If you're measuring 12 with your Pentacam and calipers, Iowa Master will be 12.5, 12.4. You overestimate. So we still look at the DFU, but then Safe Vault. That's our main metric now for ICLs.
Great, that's wonderful to hear. One last question. And most ASOCTs don't have an objective scoring for accuracy. Does the Anterion? I'm going to answer this one for you, Dr. Rocha. This one,
Yes.
We do not have an objective scoring for accuracy. However, we do apply indices of refraction for different structures to the images in the metrics app. That will apply true to scale measurements in the metrics app. So we do know that they're accurate because we have applied this indice of refraction. But we do give you the ability to look at those images in the imaging app also, which don't apply the indice of refraction, but you still can make some measurements. They're just measured in pixels in air. So you can do it both ways on the Anterion, essentially. So. Okay. And any last minute questions, I think we'll save for a follow-up email if we get anything here in the next few minutes. But I just want to say thank you again to Dr. Rocha for a wonderful program. And then for our audience, if you are looking for a recording of this webinar, it will be posted on our website. And if you're looking for any additional educational materials, you can always go to our website at he-lounge.com and like us on Facebook, Instagram, and we'll we'll look forward to the next one. But thank you again, Dr. Rocha. We really appreciate your expertise. It was a pleasure seeing you. And thank you to the audience for attending tonight.
Thank you. Thank you for having me and letting me share our experience. Thank you.
Thank you.